the other thing is.
What are we scheduled for, an hour or 2 hours? It won't be 2 hours. But I'll be starting to run out.
Nobody wants. Well, I mean, we've got
Okay, so about ready.
that is.
Okay, thanks. That's it, yeah. So, yeah, okay. Okay, and then I'll put this in there. I'll be right back. Hello, how are you today? Good. Hey, Lisa, how are you?
Good.
See what I need and then
Say who? Who?
maybe I didn't
They
notice
were like,
Yeah, that freaks me out too.
I did clean it.
So fresh. Stephanie, is this you?
That's
no,
me.
I'm on the one. You're there? Yeah. Oh, either way. Just do that. And then
Just because Allison's here. Surgery.
and if you have
Oh, okay. And go ahead and email it to me.
okay.
Because then I can like get. Perfect. Yeah, I didn't even really notice that. Yeah.
Okay.
How about today?
Well, this is about the number who came last time. We have our trustee group that comes back all the time.
All right.
Did you not set it up? I did. Yeah, I did. I did. Thank you. Good. So the last few lectures that I gave were general lectures, and they had to do with left to right shunts and obstructions, and I did talk about some specific lesions like transposition, truncus, and so forth. And you recall I showed some pictures, but we never really went into any of them with any kind of depth, I don't think. Some of them perhaps. But so today I'm going to talk about something that's quite rare in congenital heart disease, and that is congenital anomalies of the coronary arteries. So most of you, and many of us, know about coronary arteries, and that, I mean, even 20 years ago, you did. How do we turn that off? How do we turn this off? Or is that next door? Leave them alone. Leave them alone. Leave them alone. They'll think we're too highfalutin. We can talk about them. And so we think about coronary. I had that poor guy, that 85-year-old guy or that 65-year-old guy, had a coronary and died. And so the coronary means that he had a coronary obstruction, and then that's how he died. That happened a lot until, of course, coronary bypass and stents and so on and so forth. But there are such things as congenital coronary problems, and we're going to talk a little bit about them today. Now, they can be broken down like anything, can be broken down into categories. Remember, that's the way the mind works. We have a hierarchical system by which we learn. We learn that baseball is divided into National League and American League, and the National League has 3, and then da-da-da-da-da, and that's how we do this. By the way, did any of you see the Yankees and the White Sox yesterday? Wasn't that awful? If you're a Yankee fan, here we are at the top of the 9th, and they're winning 3-1. The Yankees are, and then there's a tailor-made double play back to the pitcher, turns around and throws it into right field, left field, and then the next time the guy gets up, hits a home run, of course, and that's it. It's an awful way to spend your evening if you care about those things. I mean, you like baseball?
A little.
Yeah. I was talking to somebody from Germany, all due respect to him, and he said, "Oh, soccer is a much better game, and that this baseball thing is silly and so on." And if he just understood, that it's probably the most intellectual game the world's ever known, and if he grew up with it, maybe he would understand, but it's too late for him. And anyway, we really don't care. So getting back to this National League and American League thing, we have the congenital lesions of coronary arteries. We could have anomalous origins, and guess where they could come from? The pulmonary artery. Can you imagine? Unoxygenated blood being carried through a coronary artery, such as the left main, into the heart, and guess what? The heart doesn't like it. It gets dilated, and it doesn't function very well, and so forth. That has to be taken care of. There could be critical left main stenosis, just like the stenosis that occurs with atherosclerosis. And there could be coronary artery fistulas. I'll show you some examples of that. And then there could be anomalous aortic origin. Here we have anomalous pulmonary artery origin. There could be anomalous aortic origin. You know, these kids who play football, they're 16 years old, strapping young boys, boys mostly. They're playing football. All of a sudden they drop dead. This is what they have. Anomalous aortic origin of the coronary artery, sadly. Any of you know Pistol Pete Maravich? No, he was a basketball player. He was a white basketball player, which is very unusual. And he would be able to look down and dribble like this and look down, and then all of a sudden just take the ball around, and then halfway down the whole court do this, and the guy's open in the corner, and he shoots it for a three-pointer. The guy was just an incredible guy. He died from this. Pistol Pete Maravich. Great ball player. I think he was from Louisiana. Then there's something called intramyocardial coronary arteries. These are coronary bridges. You know, if you look at the anatomy of the coronary arteries on the heart, they are surface. They're on the surface, epicardial surface. Some of them go deep into the muscle, and when the muscle squeezes, it also squeezes the coronary artery can that conduct blood through to the system, and patients can get ischemic on that basis alone. Then there are acquired lesions. And what acquired lesions could these be? Kawasaki disease. Any of you know what Kawasaki disease is? Show of hands. Okay, and what's your understanding of it? Lisa, what's your understanding of Kawasaki disease? It could be an autoimmune process, yeah. And at least that's what some people think. And then why am I showing it here? Aneurysmal lesions, right, exactly, of the coronary arteries, right? Yeah, there could be other arteries too, but they could be aneurysmal lesions, and they can cause ischemia, infarction, and death. So these are problems as well. And then there's iatrogenic injuries. What are iatrogenic injuries? What are iatrogenic injuries? Iatrogenic.
Unknown origin?
No. Good try. So iatro, ancient Greek word for doctor. Genic, cause of. Doctor causes problems. Iatrogenic, that's what it means. That's something that you should remember. If you don't know it, put it down, memorize it, and then write a paper on it. No, you don't have to write a paper on it. I was just joking. Iatrogenic injuries. And then sometimes we operate on coronary arteries ourselves, right? For arterial switch operation, we take them off somewhere and put them somewhere else. Just by doing that, suturing and all that stuff, that could cause problems later on, and I'll show you some examples of that. Well, this is an anomalous pulmonary artery origin of a coronary artery. This is what the coronary arteries look like normally. If you're the surgeon here in the non-facing sinus, you look on the right, and it's the aortic cusp, and this is the right coronary artery. And the left, and the cusp number 2 is the left main coronary artery. In those patients that have abnormal origin of from the pulmonary artery, it looks like this. This is the pulmonary artery. This is the left main coronary artery. Alcapa, not to be confused with alpaca, which is right. We've already lived through this, I think, before the previous lecture. Anyway, the coronary arteries start out from the back, from the periphery, on the heart, and they form during embryologic life, and then they eventually come together and attach themselves to the aorta. Something happened here where this coronary artery missed its target and attached itself up here. That's how that works. It's an embryologic development. This is what it looks like on an MRI, magnetic resonant imaging reconstruction. And here's the pulmonary artery. You can see the left main coronary artery coming off of here. It really comes off the back. It's not showing this well. This is how the operation is performed. You can see here the cartoon showing the aorta and the pulmonary artery. Notice the left main coronary artery coming off the pulmonary artery here. The patient is placed on cardiopulmonary bypass. Here's the catheter. Here's the catheter. Here's the catheter. You see, and then this is the aorta. And the patient is giving the so-called cardioplegia. Goes through the heart. Put ice on the heart as well. And then you cut the pulmonary artery in half and cut this main coronary artery, left main coronary artery, away from its sinus of Valsalva here. And the idea is to put it over here. That's what it looks like. This is the coronary artery here. This is the aorta. This is the place from which it came, the pulmonary artery. And the idea is to take it over and put it in the ascending aorta here. Here's the patch. Here's the aorta here that's open. That's what it looks like sewing it into the open aorta. This is a patch of the aorta as well. And you can see here coronary artery being sewn to the ascending aorta. Here's the proximal pulmonary artery, the distal pulmonary artery. Once this is here, we take the cross clamp off and start warming the patient, putting in a piece of pericardium, you see this, into that area where we took the coronary artery off. That's what it looks like. This is what it looks like it's finished. Here's the pulmonary valve. Here's that piece of pericardium to reconstruct the main pulmonary artery. And then distal pulmonary artery, proximal pulmonary artery, putting it together. And it looks like this. This is the end of it. This patient did well and continues to do well. Well, we operated between these years at Children's Memorial Hospital 28 patients. So that's about 2 a year or something like that. I don't know what is the arithmetic. There were no operative deaths. We published these papers because of the way we did it. We didn't even use any ECMO on these patients. And nowadays, ECMO is used quite a bit. I think it was the way we handled the myocardial preservation and so forth. Anyway, actually one patient had ECMO. Now here's an interesting thing. And let's leave this Al Kappa now. Let's go on to the idea about can you do a coronary bypass in a child? So in you and I, we could take our veins or do the internal memory artery, right? Internal memory artery in me is about 2 to 4 millimeters, maybe 3 millimeters. Coronary artery is about 2 millimeters, maybe 2.5, maybe 1.5. And so you use glasses. That would be it would be a relatively simple operation as long as you know how to do it and you practice doing it and so on. So how about a 2-day-old baby? What about a 1-month-old child? If I have a coronary artery that's 2 millimeters, and I'm, let's say, 75 kilos or 70 kilos, and the baby is 3 kilos, does that coronary artery, does that go down to that size proportionately? It's a very important question to ask, right? Because if it does, then you're down to, 0.2 millimeters. How the heck are you going to do an anastomosis on 0.2 millimeters? It's a very important question to ask. And it really hadn't been asked before. So because we were having these patients with Kawasaki disease and they needed some problem, they needed a coronary bypass, we looked at just regular old arteriograms of babies and adults. Well, we did a coronary angiography on. Let's start here at the adults. If you expect the vessel diameter to be about 2, based on 2 over the basal surface area, these are adults. In other words, at this level, 2 millimeters is about right for a 70-kilogram person. However, if you come down in age group, down to here, these are the children, and the coronary arteries are much larger based on their body weight than you would expect. And that's the way the curve looks like. So in other words, here is what you would expect in adults, and then if the proportion were correct, then this line would be straight across. But it isn't. So if you look at the coronary arteries on a baby, they're huge compared to, what you would expect. So that was the rationale. And we published this. And that was the rationale for being able to do a coronary bypass, as you can see here, in patients with Kawasaki disease. So here's a 5.5-year-old a girl with an aneurysm, which is huge here. You see that? That's the aneurysm, right? And it's a saccular aneurysm, quite large, and it had a stenosis in it right about here. And we were able to do an internal thoracic artery bypass graft to here. Now, this was about 1.5 to 2 millimeters, and this is about 1.5 millimeters distally here. We did it here. And this stays open. here's a pre-op on a patient with Kawasaki. This one about a 6-year-old girl. Notice the aneurysm here in the left anterior descending coronary artery, aneurysm here in the circumflex coronary artery, and an aneurysm here in the right coronary artery. And this aneurysm caused this vessel here. You see this? That was occluded. And the only reason that there's filling here is you see these collaterals? Those developed with time. So this patient was having angina pectoris, angina, pain, chest pain. And so we took her to the operating room, and this was almost an unprecedented case because we used 2 internal mammary arteries. Up until this time, most of the experience was with 1 internal mammary artery. So we used 2, and then we put it here into this LAD, which worked out quite well. You can notice that it fills all the way back. And then we also did it to the right coronary artery, and I would challenge you to with this internal mammary artery to the coronary artery, where is the anastomosis? Now, I know it to be here, but the anastomosis can be done carefully enough, and I used interrupted suture technique here to do this anastomosis, and it works out quite well. Now, if you recall, this one here was a problem, but I didn't have a 3rd internal mammary artery. In humans, things come in 2 for the most part, even the right and left side of the brain. So I didn't have enough to do that 3rd one. So I did with the 2 and cast fate to the wind. And 4 years post-op, she now is 10 years of age, and she comes into the emergency room with evolving myocardial infarction. So I'm thinking that, my goodness, you know, one of my grafts, and these are my grafts, you know, I take possession of them, even though they belong to her. They're my grafts. I did them, right? My patient, my responsibility. It's all about that. And so I said, okay, take her to the cath lab, find out which one is down. Maybe we can do something about it. So we do on the right side, and it's open, see? On the left side, and it's open, see? And then we do the injecting of the native coronary artery, and guess what? The one that I didn't do the bypass graft closed down. Natural history. Closed down. So God bless them, they put a wire in here, and they used some drugs, and they opened it up, and they were able to save this distribution. Notice this is a pretty big artery here. And so she actually didn't lose very much function and did well thereafter. Here's an 8-month-old, maybe the youngest one. How do we know he had angina pectoris? Every time he started eating, he started crying. I mean, is that angina? I don't know. Couple it with this coronary artery here, which is almost occluded. I don't know any baby that when you start feeding them, they start crying. Usually they're happy. Of course, he could have had colic and so on and so forth. But it seemed like this was a problem. And also, the EKG showed some ischemic changes on his right side. So we took him to the operating room and did an IMA here. Notice that this is the stenosis, and the bypass graft goes over here. 2 years later, we decided to cath him to see how it looked. And lo and behold, look what happened. See this? Almost, it's occluded. No occluded. So he revised, or he didn't revise. What's the word I want? He remodeled his coronary artery. It came open. He absorbed it, whatever the obstruction was. And then now this coronary artery, this bypass graft is open, but since it's collateral, it's a competitive flow, it has degenerated into what's called a string sign. Now, if this patient, and this has been known, if this patient gets another stenosis here, then this thing will actually grow to where it was before to supply. So it's good to have the belt and suspenders. Now, this is a 5.5-year-old child. Look at this. 1, 2, 3. Amazing. So we did a free bypass graft here to the coronary artery, and then on the right side, and an LAD here to a left internal thoracic artery to the LAD. So this patient had a giant right coronary artery aneurysm and a right coronary artery and LAD stenosis. So she had bilateral coronary arteries. This was done at 7 years of age. 4 years later, we wanted to see if these were growing. They were, in fact, growing with her, and they were still open. And that's the natural history of internal mammary artery bypass grafts. As the baby grows, the arteries grow. If you use veins, the veins don't grow. That's why we use the arterial system. Here's a 2-day post-op Kawasaki patient. This is one of the few times that we did a right internal thoracic artery to the back of the heart. This is the obtuse marginal. I think when I did this, I spent about 15 minutes just to make sure it was lined up properly, because you're doing it into the back of the heart's up like this. It would be very easy to turn this around, to have it confused. Everyone thought I was neurotic. The fact that I was neurotic and the outcome is really irrelevant. The fact is that it worked fine. But these are the kinds of things that if they're only 1.5 millimeters, you better have it right. Otherwise, it's just not going to work. So we had the LAD here, and we have the circumflex coronary artery here, or the obtuse marginal. And this was 2 days after the operation. Now it's 1 year after the operation. It's still working, both of them. And then 4 years after the operation, still working, both of them. So we have evidence here that these things do work as long as they're done properly the first time. This patient had a right coronary artery aneurysm, and the idea was to go in and evaluate things. And you see this? This is the left coronary artery. You see that? Here's the left coronary artery. Here's the left coronary artery. What happened here? What's that? Clot, yeah. Well, what happened? Why was the clot?
From the aneurysm?
No. It's a good intuitive thinking. But what happened here? What was that word I mentioned that
Doctor
you?
Did it.
Ah, doctor did it. Blasted doctors. That's right. Specifically, a pediatric cardiologist who specializes in catheterization did it. So look at that. Now, this family was quite livid about this. Well, there was no choice. I had to take this patient in the operating room, and I did. And you know, all these arteriograms that I have post-op. You think I could have gotten a post-op arteriogram on this patient? No. Mom didn't like anybody. I guess she liked me well enough, but not so well that she would consent to another arteriogram. Anyway, the patient, I'm sure, is okay. So we had 9 patients like this. The early patency was 100%. And one of them developed an occlusion late, but the results are by and large pretty good. Now, so we have other patients that have coronary procedures who have left coronary atresia. Can you imagine this? A baby is born with the left coronary artery occluded or atretic. So you say, how could that patient live like that? I'll show you how. Some of them have single coronary arteries. One of them was a Al Kappa redo that was done. And then there was another one with anomalous aortic origin. Now, see if we can see this one. This is pre-op. The injection into it's hard to see. I'm going to have to explain it to you. Injection into the ascending aorta. Really what you see is this, right? Right? Coronary artery. Where's the left? I don't see it, Dr. Mavrutis. Well, I don't either, except maybe there's a hint of something here lighting up from here, going across through capillaries within the heart, going to the other side and filling retrograde the left coronary artery. See? So we say, okay, this must be anomalous pulmonary artery origin of the left main coronary artery, right? Of course, that's what it is. So we inject the pulmonary artery, and lo and behold, there's no coronary artery. So the diagnosis is left main atresia. And so what we did was to operate and cut the aorta in half, and then make an incision down onto where the atretic portion was, lay it open. Now, this is a 5-month-old child here, right? Lay this open, and I took a piece of, not pericardium, at least I think I took a piece of pulmonary artery, because I know that from a paper that I read actually about 4 months before this, I know that if you take the pulmonary artery patch, it grows with the patient. And then I replaced the pulmonary artery with a piece of pericardium, which is no problem. And so I put this as a patch down right onto the coronary artery. So we couldn't come off bypass. Couldn't come off bypass. And so we were either going to do ECMO or we were just going to say, well, we did the best we could, you know how that goes. We did the best we could. There's nothing we can do. And that's sad, you know, because that's sometimes you have to say that. It's because there isn't anything more you can do. So my associate looked over to me and he says, look, why don't you do a coronary bypass on this? I said, well, you got to be nuts. This is, you know, the most 0.8 millimeters. And he says, well, come on, let's do it. I mean, I really didn't. I said, okay, I was persuaded by him. So we go back on the heart. I mean, well, we never got off the heart-lung machine. So we give the cardioplegia and so forth, and we do a 0.8 millimeter IMA to a 0.8 millimeter coronary anastomosis, and here it is right here. And this patient came off bypass, survived. And then when we did the arteriogram, we found out that this was open. Why that she needed this, I have no idea. Maybe this was spasm, I don't know. So this she really doesn't need anymore, but it was enough to get her off the heart-lung machine, and she survived. Here's a baby about a month old with congenital osteoatresia. This is what it looked like. We did a coronary bypass graft here. That was enough to work, but the left ventricular function was poor. She needed a cardiac transplant, and she died 2.5 years postoperatively. So what are you seeing here? You're seeing follow-up arteriography. You're seeing follow-up of outcomes, aren't you? Right? That's what we have to do, don't we? Right? We have to follow these patients for life. And if there's bad news, well, you have to say it. Now, if there's too much bad news, then you have to find another job. But you know, you have to say it. You have to say, okay, how can we do this better the next time, and so on and so forth. So here's a patient who had an aortic homograft with a presumed single right coronary artery, and it was coming from here. In fact, this patient had left main atresia with a right coronary collaterals, and I did a bypass graft here while I was replacing the ascending aorta. In the old days, when we're talking about (1983, 84), and this patient, we did a cardiac transplant on this patient in 1990. And we did a cardiac transplant for hypoplastic left heart syndrome. We wouldn't do that today. We would do Norwood operation because the Norwood operations are much better, and so on and so forth. And you can't get hearts anymore anyway. And so the heart that we put in the baby had a single coronary artery like this. And the main coronary artery here, the left main coronary artery, was going between the aorta and the pulmonary artery, and there was some squeezing going on. And at 4.5 years of age, 5 years of age, she was acting on the stage and was falling out continuously, fainting, et cetera, et cetera. Here she had a heart transplant. What's going on here? She's not taking her medications, et cetera, et cetera. Well, that's not the case. So she happened to be the flower girl of one of my nurse practitioners. And I really didn't know what to do with her. And so I said, well, look, you know, we can do a coronary bypass. Let's see how that goes. So we did a coronary bypass, I think, 2 weeks before the wedding. So I had some pressure.
Yeah.
So we did a coronary bypass. Here, you can see it. Here's the internal thoracic artery. Look what it does. It lights up the whole heart. One coronary bypass lights up the whole heart. Isn't that amazing? So she went, put a dress on. Still had steri strips on her wound. And she marched down the aisle. I saw her. Was at the wedding. And she never had a spell again. And then she lived. As far as I know, she's still alive. She does have some transplant coronary artery disease unrelated to this. But that's a very interesting case. You know, you put in a heart, but the heart is associated with sudden death. Here's a patient who had an almost left main coronary artery from the pulmonary artery, L kappa. And the only reason, in the old days, you take this left main coronary artery coming from the pulmonary artery, and since it wasn't easy to transfer it, they just ligated it, thinking that it would not run into the pulmonary artery, and then the collateral flow would work, and it actually worked here. You see, this is collateral flow. You see these arteries here that are filling this left coronary artery? They come across from the right coronary artery. So we took this patient to the operating room and did a coronary bypass. Well, we're getting to those patients that drop dead, you know, those poor kids who are great athletes and then just drop dead. This is an almost aortic origin. This is the left coronary artery. This is the right coronary artery. Notice the artist did this appropriately. The orifice is about half the size of this, maybe a third the size of it. That's accurate. And then the course of the coronary artery runs within the wall of the aorta. Not outside, within the wall, right? And this thing can become stenotic. It can, depending upon how much pressure there is within, it can cause a decrease in flow in this coronary artery. This is called right from left. So the idea is to transect the aorta, unroof this area here, and then tack down the edges here, and you can see that that's how this works. Now, sometimes this thing runs below the commissure, and then the idea is to respect the commissures of the aortic valve and not take this down, but make a hole distally here. Notice here we leave this alone, and then tack down this, and then that works pretty well. This is the left from the right. This is the dangerous one. Happily, it's about a third the incidence of the right from left. This is left from right. Here's a right coronary artery. So you remember who used to do that with some regularity? You remember Clouseau? You remember? Come on. You don't remember A Shot in the Dark? You remember Peter Sellers? One of the greatest comedians ever to live. He's dead now. The Pink Panther, right? Wouldn't he do this? Go over there and he'd just sort of fall.
I have a question on these.
On Peter Sellers. Huh?
Well, no, actually. How do these kids get diagnosed?
So, how do these kids get diagnosed?
Undiagnosed. Do they have symptoms or?
So usually the left from the right has symptoms. They have ischemic symptoms, chest pain, and then they get an echo, and then it gets picked up. If you get an echo and it gets picked up, and then you do an exercise test, the exercise test almost never positive, almost never. Because when you're doing the exercise, most of the time, it's open. It's that once in a blue moon when it gets closed, and then you wind up dying. And so, what we have autopsy studies. We have anecdotal information about, you know, Pistol Pete Maravich and the autopsy and so forth. So that's how they come to it. So at the moment, if you're over 4 years of age, in my practice, and you have right from left, I mean left from right, then that's an indication for an operation. Right from left is not necessarily an indication for an operation. I think we have to have some other findings.
But
if you go, yes, and an MRI.
Okay.
Almost all of them get MRIs. And interestingly, I just came back from Philadelphia yesterday at a national meeting, a group of people who are studying these things prospectively. So we are going to put whatever cases we have, we're going to put them in this database and follow them. Already we have some cases that we've been following. The kids, you know, 2 of them dropped dead. We had 2 others who had an operation, and they died. Now, we're talking over 200, 280 cases. But then, you know, you're saying, well, look, you know, are we really doing anything here? I mean, are we going to have some kids who just have the operation, go home and die? Some kids who don't have the operation, go home and die? So we're going to try to get all this information and sort of get it out there and say, okay, this is what you have to do for this. This is what you have to do for that. This is what you have to do for that. So this is the left from the right. Left from right, and now the difference here is that you see this is below the commissure, so you have to make 2 holes here. This is above the commissure, so you just incise it all the way out here. This is what it looks like in the operating room. This is a left from right. This is the right coronary artery. Here's the commissure. The left coronary artery has to be here. This is the left that goes through this tunnel here. You see this? This is within the wall. It's coming. You can almost see it coming there from the light shining on it. Aren't these beautiful pictures? I don't remember who took them. So then you start opening this up. Look how thick that is. Look how thick it is. See that? That's very thick. That we first of all incise it, and then take this common wall out. You see this is a scissor here, a knife rather, scalpel. And then look how big it is once it's finished. You see these sutures? These sutures take the intima of the coronary artery and the aorta and bring it together. If you count them here, more or less they're about 18, 20. So each time I do it, let me see, it takes about 15 seconds each one. So it's no small matter, maybe 20 seconds, whatever. And these are all 8.0 prolines. 8.0 is about the size of your hair. So you got to be real careful when you're doing this stuff, right? This is what it looks like at the end. Look how big it is. These patients did. I did 2 brothers like this. It's familial. Here is a right from left. And you can see here is the left coronary artery, and then the right comes that way. This is the one that's not as dangerous but can be. Notice the sutures that are placed there. Okay. So who wants a good question? You want to try a good question? Try it. What do we do when we do a arterial switch for transposition? We're switching the pulmonary artery and the aorta. This is an example of non-verbal expression of, is there something else?
I'm not sure what the something else is, though.
If you do what you just said, patient's dead.
Well.
Okay, hands. What did she leave out? Let you think.
So,
Can't think too long now.
I think it's when the pulmonary is attached to the left ventricle and the aorta, it goes to the right ventricle.
Okay, so.
So, I think what you do, or you make the right ventricle
That's what she said. That's what she said. No, she said you switch the vessels. Yes.
Yes.
What else do you do? Want to try it? You move the coronaries, right? Okay. So in the act of moving the coronaries, right, there may be some misadventure. Maybe. Right? Could be. So we've operated on a few people like this. This is a baby who was operated on at some hospital in Chicago, came to this hospital where I was at with an occluded left main coronary artery. The ventricle was not even pumping. Took her to the operating room and did a coronary bypass here at 2 months of age. I think she's still alive. And we lost follow-up on her. It's possible that she died without a transplant. She probably would have required a transplant sooner or later. Here's a 10-year-old who had this is after the operation, who had a stenosis of the left coronary artery because of rotation, the original rotation. And so I took them to the operating room, unrotated it, and did a coronary bypass. I did a pants and suspenders technique. Fix it from the front and also fix it in the end of it as well. Here's another patient that we did a coronary bypass to. This is a pretty tight stenosis here. And we did a coronary bypass there. Here's one with really tight stenosis. You see that there? She also did a coronary bypass here. 3 years later, it's still open. Here's an interesting case. 11-year-old was done at an arterial switch operation in New Jersey, I think, and was doing reasonably well, but couldn't keep up and had some chest pain on exertion. And we did an arteriogram on him, and we did a right injection. Look at this. Comes back to here, and guess what happened? Left main was occluded. Probably occluded at the first operation. And fortunately, was able to live through it because of collateral flow. If there were no collateral flow, then the baby wouldn't have been able to live through it. So because of this, and there was only one coronary artery that was open, we did a coronary bypass here, and that worked out fine. It did all right. Here it is again, same thing. Here's a 7-week-old infant, a baby that I did a arterial switch on. And I switched the left main coronary artery appropriately, put it onto the new aorta, and I saw that the button that I put on there had an intramural course to it. Remember that other one I showed you, that intramural, right from left, left from right? Remember that? This one was the same thing. But I figured, well, if I opened it up, it's going to fall apart. It's open. See how it goes. The patient did okay. 7 weeks later, comes back with a myocardial infarction. Take the operating room, tried to fix it. I couldn't, and the baby died right there. Now, there are some patients that had a Ross operation. Ross operation. Who wants to try that? Want to try it? Usually a homograph, right? So those of you who didn't hear her diminutive voice, she got 100 on that. So you take the pulmonary valve and put it in the aortic position. That becomes the neo-aortic valve, neo-aortic valve. Then you take from the freezer a pulmonary homograph. It's from another human being, thawed, of course, and put it in the pulmonary position. That's the neopulmonary artery. Neo-aortic, neo-aorta, neopulmonary artery. Okay. And of course, by doing that, you have to reimplant the coronary arteries, right? And when you reimplant the coronary arteries, that's something that could go wrong. And look what went wrong here. This is a patient that was operated on in New York City by I wouldn't call him a friend of mine, but by a surgeon who's a very good surgeon. This can happen to anyone. And it happened to him. And here's the coronary artery, quite stenotic. So I took him to the operating room and did a patch of this, and it didn't work. Had to take him back again the next day, and then now he has an end-to-end anastomosis between the internal thoracic artery and the right coronary artery, and it's hard to tell where the anastomosis is. He did quite well. Sometimes patients have supravalvular aortic stenosis. Give me your attention here. The aorta, here's the aorta, and here are the sinuses of Valsalva. Sometimes the aorta can be small like this, and the sinuses of Valsalva can be small as well, and some parts of the valve can be cutting off flow to the coronary artery. That can happen. And it happened in this patient as well here. So we did a Ross operation and an endarterectomy, and that worked quite well. Here's a patient who had a tetralogy of Fallot repair at another institution and had a rocky postoperative course, but did all right thereafter, except had PVCs. Now, if you recall, maybe you remember, I talked about tetralogy of Fallot. There were 4 different types of tetralogy of Fallot, and I'm not going to ask you about them. I'm going to tell you. One of them is irregular tetralogy of Fallot with pulmonary stenosis. Another one is tetralogy of Fallot associated with AV canal. Another one is tetralogy of Fallot associated with pulmonary atresia. And another one is tetralogy of Fallot associated with an abnormal coronary artery. What do we mean by that? It means that the left anterior descending coronary artery is not coming off the left main like it usually does. It's coming off the right coronary artery. It's coming across the outflow tract where you want to take the muscle, and it gets in the way. And if you incise it, the patient dies. And so this person did the operation through the right atrium, which is a very good way of doing it. But without knowing it, he cut off the back of the left anterior descending coronary artery, and it caused a fistula. So the blood was coming from the coronary artery into this area and into the right ventricle, and that was presenting a problem. So we did a coronary bypass, closed off the fistula, and then the PVCs went away, and the patient did well. Here's a patient who had Marfan syndrome, and I did an operation that worked pretty well. And as I was drying up, I avulsed the right coronary artery, and there was bleeding all over the place. oh my goodness, you know, I have to go back on the heart-lung machine, and I had to do a coronary bypass. What do we call this? Iatrogenic actions, right? So this can happen, and I show it to you here to say that it can happen, right? So this is iatrogenesis, right? This is a patient who I wasn't in town for, had a balloon dilatation of the aortic valve. The balloon was too big. The person who did it occluded both the right and left coronary arteries. They went to the operating room, comme ça, and they put in a new valve and coronary bypass grafts, and the patient died. Here's a patient who had orthotopic cardiac transplantation, right? And you do a coronary angiogram to look at the coronary arteries to see if they're having any obstructions and so forth. And what is this? That's a dissection. What is the word for this again? Iatrogenic. Yeah, that's, in this case, it wasn't I, it was the cath person. And, of course, we had to come to the rescue. And this is what we did. Coronary bypass, look what happened. With the flow coming back here, it fixed the dissection. By retrograde flow, it fixed the dissection. This is an 18-year-old child who I did a coronary bypass on 20 years ago. I operated on 2 years ago, but 20 years ago, I did an arterial switch. And I transferred a artery that was intramural, but I didn't unroof it. He did fine for 18 years. And then he had a falling out death spell. He was resuscitated, placed on ECMO. He lost his foot. This all occurred in Florida, I think. Here? Somewhere on the East Coast. And they called me. I said, come in. And he had that intramural branch, intramural artery that I transposed, but I didn't unroof. He had a death spell from it. And we took him to the operating room, and I don't have the pictures here, but there's some very nice pictures showing that I unroofed the artery and put him back together again, and he did fine thereafter. I mean, these things happen. It's not just, you know, they happen. This is a 16-year-old intramural left coronary. That's the same person. And this is a postoperative echo. I can't tell you, but I'm told it looks good. Then we have a bunch of other iatrogenic lesions. Look at this. Here's a patient who had a conduit from the right ventricle to the pulmonary artery. Sometimes there's no pulmonary artery, so you have to reconstruct the pulmonary artery. So you take a tube with a valve in it that's called a conduit. And you sew it from the right ventricle to the pulmonary artery. But sometimes there's a coronary artery underneath it. And look what it can do. It could compress the coronary artery. Here's the conduit. Look at this. It's compressing. This patient had angina. Not too good. So we took it to the operating room and fixed it. And it got better. This is another one that had similar kinds of things. It wasn't a very good arteriogram. The iatrogenic lesions turned out to be the worst because there are 4 out of 12 deaths here, 3 early and 1 late. Some of them were due to a Norwood operation, one after the balloon dilatation I talked to you about, and another one was a presumed conduit compression after a replacement. If you recall, I talked about patients that have an intramural course, that when the heart squeezes, it also squeezes the artery, and that can cause ischemia in that kind of way. Here's a patient who had pre-op in systole, and there's supposed to be a coronary artery here, and there really isn't. This is in diastole. Look, it is there. In systole, it's missing. It's supposed to be here. Here it is right there. So in diastole, it lights up, but in systole, it goes away. This is the EKG. Those of you who recognize it, there's a Q wave here. And there's a Q wave here in F. F2, maybe not so much 3, but certainly an F, indicative of ischemia. Took the patient in the operating room and filleted open the entire LAD here, and there was a lot of muscle on top of this. So I just opened it all up. And then post-operatively, this is what it looks like in systole and diastole. It's open, both measures. It took care of the problem. The EKG normalized. He went home, and 2.5 years later, he dropped dead. I wish I had him back again because I would have looked at the proximal coronary arteries. You wonder if he had something there, too, right? This is a long time ago before we were looking at that. It's tragic. Some of these things are tragic. You do the best you can. No one wanted to do this. I said, okay, let's do it, see what happens, and so forth. So we had to, then after that, we had this 15-year-old who wanted to play soccer. He lived in Miami, and he came up to Chicago, and he had this, couldn't see the coronary artery, and this is in diastole, couldn't see it very much. Systole, you could see it even less. So we took him to the operating room. Look how thick this is here. We're talking about almost 1 centimeter, maybe more, that I had to dig out the coronary artery, all the way, the whole length of it. And look at this now, in systole and diastole. And he went on to have a relatively good career, so if you want to call it. In soccer, he did very well, and I've been following him, and he continues to do well. So coronary artery bridging, you can say that at least the anatomic result is good, but we had one late death, I guess it was 2 years, not 2.5. And this one excellent result now is more than 5 years, and he's doing quite well. Okay. If I say fistula, what does that mean to you? What does that mean to you, fistula?
Something is done, and then one vessel attaches to the other.
When a vessel attaches to the other vessel. Which vessel attaches to which? Retrograde. Oh, you're doing all right. You're doing all right. Fistula. One vessel attaching to another one. I like that. Which vessels? Any. Want to try it? My diminutive friend who knows everything. I mean that in the greatest admiration. No, but I am thinking about an artery attaching to a vein or an artery attaching to a chamber of the heart. In other words, an artery going somewhere where it shouldn't be going, a fistula, right? Now, are there other fistulas? Yes, there are bowel fistulas, right? Going somewhere where it shouldn't be going. There are fistulas that are really catastrophic. For instance, there can be an esophageal aortic fistula. Think about that. Ruptures, and the aorta ruptures into your esophagus, and you can bleed out that way. Right? So anything that's an abnormal communication can be called a fistula, right? In this case, we're talking about fistulas in the heart, arterial fistulas that go to chambers, otherwise known as cameral. Camera. What is a camera? Bicameral legislature. What does that mean? Bicameral legislature. Cameral. Camera, from the Greek camera. What is it? Bicameral legislature. 2 houses, 2 rooms, right? So that's how it goes in political science. In this case, a camera, if you will, is a chamber of the heart. Right atrium, left ventricle. So the origin, of course, either from the right or left coronary artery. It doesn't take much to figure out that it's going to be one or the other. And then the drainage can be in any of these structures, including the SVC. Okay, so here's a coronary artery. Coming down here, it's a rather large serpiginous one, and a left coronary artery, and both of them empty into this right ventricle, otherwise known as a fistula, into the right ventricle. And the way you can do this, sometimes you can do this without using the heart-lung machine. You just open up and then do the dissection on top of the heart. You don't see any catheters here, and then you can find it, and you put something around it, and you ask your echo people to come down, and you cinch it down. Is it closed? And they say yes, tie it, and you go home. Sometimes it has to be inside the heart. You have to open up the heart. That requires a heart-lung machine. Notice the catheter is here, and you have to close it from the inside. Let's try to explain this one. Here's a little baby, just born, with a chest X-ray like this. There's a continuous murmur, and the heart's quite large here, heart failure. And the echo, here's the right ventricle, here's the left ventricle. Left ventricle comes out here, and there's something here that's not supposed to be there. It's something large coming out of the ascending aorta. And when we looked at this, there was a large communication from the aorta coming down here and attaching into the right ventricle through a chamber here, through a tunnel. And so I operated on this patient, and I couldn't find the distal right coronary artery. So I didn't know whether to close it off here or here, because I really couldn't find this. As probed as I might, I never could find it. It was somewhere, I couldn't find it. So not serendipitously, but with some informed idea, I decided to close it here because I was worried that there could be a coronary artery coming off of here. I did that, worked fine, and then we did an arteriogram and showed that the coronary artery was indeed coming off there. If I closed it off earlier, we would have had a problem. So this can happen. This is a coronary problem. It's a fistula. It could happen in infancy.
So what is it attached to?
Attached to the aorta. And then it went into the right ventricle through a very large fistula. I mean, as large as my finger. Nowadays, many of these are closed by coil occlusion and so forth. But that baby was way too small for that. Nothing could happen with that. That was 55 minutes. So what kind of questions do you all have now? Yes.
What is unroot?
What's that?
I'm not familiar with the term unroot.
Okay. So, yeah, of course I can. In order to unroof something, it has to be a pathway in something that when you unroof it, it goes into that, whatever that is in. For instance, if I have an artery on the outside of the heart and I open it up, then the patient will bleed to death. But if that artery is going inside of a chamber, if I open it up, then it goes into the chamber. For instance, a coronary sinus is within the heart, and it drains into the right atrium. But if I want to unroof it, and I want to make it go into the left atrium for whatever reason, all I do is open it up, and then it drains in the left atrium. Unroofing, taking the roof off. Maybe I explained that well. Maybe I didn't.
Yeah, I think I get it.
So, but in order for it to work, it has to go into has to be in an anatomic position where when you take it off, it goes into something. Otherwise, you'd have to put a patch in it or a tube in it to put it into somewhere else. Unroofing.
Okay.
Any questions?
So balloons can be used, but like in the valves or in the coronaries, no such thing as stents. The baby will.
Yeah. So yes, correct. So you're asking the question, or you're making a.
I'm not sure.
Yeah. Okay. All right. Yeah. So it's a good discussion point for this, because stents are used extensively in congenital heart disease and congenital heart surgery or cardiology. So you know about stents that are used in coronary arteries, and ordinarily we wouldn't use stents in a child because you don't really know how long that stent will work. It does build up with neointimal hyperplasia, and we don't have any long-term, 20-year follow-up on stents in the heart. And anyway, there is a growth issue and so forth. However, we do use stents in pulmonary arteries. So when you think about stents in congenital heart disease, they're usually used in the pulmonary arteries, but they're not used in babies in pulmonary arteries. We use balloons. And then stents are used when their patients get to be over 5 and 6 or 10 or 12.
So you're not concerned about growth?
We are. And I'll tell you what the answer to that is a recatheterization and reballooning, because these balloons are made such that they can actually be ballooned up. Yes, we're very much concerned about that. And so the balloon is used in little babies, and then the balloon and a stent is used later on. And of course, the balloon, the so-called stent, and the melody valve can be used to put this valve in the pulmonary artery position, enlarge it, and then you have a valve that's already there to be used. Anything else? Anybody else have any questions? That was a good question.
Yeah, it was.
So was yours. They're all good questions. Any other questions? Now, we're supposed to be 2 hours. Is that what your CME scheduled you for, 2 hours? Or is this...
We didn't get
Did you get CME? Okay. I mean, I have other lectures here. I could look them up, but I don't know whether that, I sense that you're tired of it. Yes.
Jessica's here from palliative care. One of the questions we had was we have children who have trisomy, 18s, et cetera, and there's always a dilemma as to some cardiologists will do surgeries. I mean, there was a time when they didn't even do surgeries on the trisomy 21s, but now they do very standardly. I guess our question is, our thoughts on that?
So what we're talking about is philosophy backed up by data. We're talking about biomedical ethics. We're talking about fetal diagnosis. We're talking about interruption of pregnancy. We're talking about the status of the family and the other children that exist. We're talking about...
Assuming there's been no interruption of pregnancy and we now have the child here, to boil it down to answerable question.
Right. I'm not pacing here because I don't know what to say. And I'm not really trying to be vague about any answers. Specifically, let's just talk about a baby with generally it's a VSD with trisomy 18 generally. Now we know that 99% of patients die within 2 years or so, for whatever reason, right? And so we also know that there exist on the internet and in the United States organizational structures and organizations that say, look, these babies can live, and they can do this, and they can do that, and they have 1 or 2 examples of this, and so on, and that we should close the VSDs. And so I think that when you approach a problem like this, it's not so easy to say, well, for every situation we do this, for every situation we do that. Closing a ventricular septal defect in a baby with trisomy 18 flies in the face of reason. And if you use reason to interpret law, and if you use reason to interpret scripture, and if you if you use reason to interpret anything, you have to weigh the balances of good and bad, etc. So I have operated once on a baby with a year old with trisomy 18 because the baby was suffering from congestive heart failure. And I knew that the baby was going to die. And so the parents asked me to operate because the baby was suffering, and I did. And then I also declined a number of other occasions. And the moral to that story is that it all depends.
Case by case.
I think so. It depends. But
So if it's a comfort measure and the parents want it done, then that is a viable reason.
maybe. I mean, if it's a comfort reason and the baby's got congestive heart failure and choanal atresia and duodenal atresia and then the comfort measure can be easily taken care of with morphine and comfort care, so to speak, which is a euphemism for, of course, nature taking its course. What I was getting to is that the basis of all these decisions should be based on reason. And I mean, that's not a cop-out either, because reason has been the enlightenment that we've all have understood to explain things. There is such a thing as reason. Is something reasonable? And is it something reasonable 2 years ago? Is it reasonable now? For instance, you brought up a good point about trisomy 21, Down syndrome, right? Well, you know, when Paul Ebert, my mentor, was doing all these Down kids with AV canal in 1978 or 77 and 76, when he was doing that, people were saying, you know, why is he operating on these patients? Well, even before that, there was a move afoot to do something, but before that, there was a move afoot not to do anything. So what was, quote unquote, reasonable then has changed to what is different to be reasonable today. Now that's a simple matter that things change, but we should base things on reason. We should base things on what reason. I mean, you can dilate on this. You know, you can go to Scripture and dilate on that, and you can start to say, well, when are Bible stories not Bible stories, and when do you interpret the Bible literally, when you don't, and then you have to say, well, what's reasonable, and how do you interpret constitutions? How do you interpret Scripture? How do you interpret anything? And then the only answer you have that is under the light of reason. That makes sense?
Yeah, but I guess then my question is...
You think I'm going to answer your question?
Well, I'm going to throw it out there. The parents want surgery done. We know the surgery is available. We know the child is going to have a limited life mortality. However, as a social worker, I come from the perspective of the patient's right to self-determination, and they're requesting the surgery.
Who is requesting the surgery?
The parents.
Well, you said that the patient has a right to self-determination.
Parents, right, and the parents are that representative for that baby.
I wish you could ask the baby, huh?
I wish I could, but I can't. So I have to defer to the parents.
Yeah. Well, I don't know. I don't know what the purpose of that would be. How many babies they have at home, what the situation is, why they're doing this, what's the background for this? Have they been misinformed? One thing, a term that I didn't talk about is informed consent. Is this something that we need to talk with the family about and sit them down and say, well, this is what's going to happen, and da-da-da-da-da. And I think that what Fortunato was saying is that each one is on its own, and you'd have to decide that on that basis. I would never, ever give you an answer about, yes, I would do this for all occasions. That's just not, I think that's too simplistic. I mean, that's just way too Patton-esque, you know.
So the next question, which is going to be easier, is, are you taking consults now?
Yeah. I mean, it's not I who is not ready. It's just the rest of us, you know. Not you here. I have full confidence in this group here. It's just that we don't have our doctors here yet. This is supposed to be a July 1, 2, and so forth. You know, the people in ICU, the PICU, and some of our anesthesiologists. I mean, I'm already operating. I'm doing adults with congenital heart disease. So, and I find that the environment to be very good. I find it to be excellent. The adult nurses in the PICU, the ICU, are just as good as I've ever seen. And I suspect that our PICU people are going to be the same. I have every reason to believe that and expect that. Even with my diminutive friend here, who I'm sure is reading everything she can get in her hands on.
Awesome.
You know, I'm just kidding.
That's why she's a CNS.
Anything else? Yes, Fortunata.
No, I was just fixing my slip. Sorry.
So was I. Okay. So I think that when we start these cases, I think, you know, we have our, you know, we have discussion by the bedside, impromptu discussions, and we'll talk about this, and that about this patient. That's what I generally do when I bring a baby back. Well, watch this, watch for this, watch for that, and so forth. So that's what we'll do. Learn together, so to speak. How many of you are coming to this lecture on Monday? What lecture? So it's a celebration of our republic.
Oh. Yeah. I'm like, Jeannie. Yeah.
I think we've had enough. That philosophical discussion just wore me out.
Just a kind of quick question in regards to what Monica had asked. So would you see those cases with the trisomies, would it start out as sort of a provider family case conference talk?
Yes.
And then progress into a full-on ethics consult should it need to get there?
Yes.
Or do they start with...
I don't think there's any question. If family wants an operation on a trisomy 18 patient, that we should have a consult, ethics consult. And I think that we probably should be making more use of ethics consult in the adult and the pediatric hospital than we do already. And so this is an interesting thought. Ethics consults, sooner or later, are going to be performed by people who are credentialed. They're going to have to become credentialed to be an ethics consultant. What is it? Consultant. So in other words, not everybody is going to be able to do an ethics consult. That's going to come within 2 years. That's the way it's going to be. I think only do about 4 to 6 a year. There are places that do 200. And of course, you know, one of the reasons is that that we don't do as many, I think, as well. We just don't think of it. And the other thing is that it's very labor intensive, and no one gets any money for it. It has to come from the organizational structure, so it's expensive.
I think here we have a relatively lower number than we do in children's, but I think that on the verge of getting ethics consults, we have like family meetings, which the providers get in there. It's not on the level of an ethics consult, but it essentially answers the questions that are just this provider not talking to this provider and the nurse is not, you know, it's the communication.
There's only one thing wrong with that. It's great. There's only one thing wrong with that. Who documents it? It's probably not documented. And something like that probably should go on the chart. And you know what else? Something like that ought to go into a database. Right. Something like that ought to be categorized in some way so that we can learn from it, all of us, right? And that we have done 25 ethics consults last year. What kind were they? Well, 20 were nuisance. 5 were this. Some were this. And then you'd come up and say, well.
There are inconsistencies. You might find parts of that conversation in a social work note, parts that might be in a nursing note.
Well,
parts
when we
of it
have
might not
formalized
be.
family meetings,
not
it's really the primary physician's responsibility to document what was discussed on the medical component. I mean, what I generally do is document what was actually.
Not exactly. And the reason I say that is because there are some institutions that do ethics consults and they don't put it on the chart.
I don't believe we put ethics consults on the chart.
No, we don't.
Well,
I'm saying the family meetings that you say.
Stay tuned. Stay tuned. Stay tuned. And then the other thing is that what comprises the ethics committee? I mean, do we have clergy from outside? Do we have a
We did have outside community.
Do we have a do we have the principal of PS 11, Public School 11 on it? Do we have
Outside.
So anyway, this is not a gloss on what we should have or shouldn't have. I'm just saying that, that these are the things that are going to start answering questions or like yours, and I think the more you include the community, the better it's going to be, and that's just the way it is. And yes, we have to make more use of ethics consults. We have to make more use of that kind of thing. And who can call for ethics consult?
Anyone.
Yeah.
However, I will say, on behalf of nursing, I think that my experience and my background in NICU, it's been difficult sometimes to get physicians to want to do that, because it's like, this is what the parents want. I've talked to them, and the nurse is feeling incredibly uncomfortable and in a very difficult place with providing care. I think we can improve.
I think there's a yeah, of course. There is on the more nefarious part is that this nurse doesn't like me or whatever, and says, I'm going to get back at you. I'm going to get a consult every time you have a patient here. Now that's ridiculous, and that's not something that we would tolerate. But I don't see that as part of the ethos of nursing staff. Nursing staff is there all the time. They're there with this family, and then you say, well, we're going to do this, but we're not going to tell them. They say they don't want to. No, they say the family doesn't want to tell the patient that the patient has AIDS, and then the nurse says, I know the patient has AIDS, and the patient's asking me, do I have AIDS? What do I say? These are problems, right? And I think these are the problems that can be figured out with with consults and everyone getting involved. That's a good thing. This is a philosophy group, I see, huh? Yeah. Well. Yeah. I think that there's a lot of things that we can bring this institution forward with. We're already doing it, right? With congenital heart disease in babies, right? That comes with it research. That comes with it internships for people who want to learn. That comes, once you have this kind of thing, it sort of starts to blossom, and next thing you know, this place will be a think tank for this or that or whatever else, right? Anybody else have any probing questions that they want for me not to answer? Okay, this class is dismissed. Thank you all very much for joining.
Please take one of the flyers about Independence Day talk back to your units and areas, please. Invite the units all.
Stephanie? Stephanie? Okay, I don't remember this. Forgive me, I just don't remember this. Okay, so you want to talk about this?
Well, but from part of it.
Excellent. I'm happy, and I know where you are.
Yes, you do.
I do.
I used temporary pacing wires selectively. Selectively.
But they seem to just about everyone.
I don't care what they do.
I know. I'm just trying to.
No, I don't mean that.
Stuff like that, maybe some.
Well, I use transarterial pacing sometimes. If I don't put a pacemaker in wire, then we'll use
So you do
transarterial.
want a basal and
We do, yes.
That is awesome.
Not be using swung gas.
Be like, oh, you want.
Yes, will not be unless they're 16 or 18 years old and for some reason.
Bye, Monica.
So I think maybe. You a nurse practitioner?
I'm the clinical specialist.
So
One more clip on the specialist? I have somebody who's requiring. Requiring.
Placing direct intracardiac lines routinely, not routinely, sometimes, but not routinely. How long
Do you have a certain type?
Sorry, I have to get them. I don't know. Whatever they have is fine. Okay. Usually use 2, maybe 3. By suture in place, yes.
One. Yeah.
One is it just goes around. What, plan to use what?
On kids, they're not getting
Where do I put them?
lidocaine kind of.
And then in one?
Yeah.
Inject it?
I believe it's sort of threaded up.
Find out what it is.
Okay.
If they like it, I'll use it.
Right. They don't use it as they don't use it at all children's and in Miami and with the kids.
We have a weekly, yes, we do.
Yay. Are we planning to have that like with anyone else or like a video conference?
They have a video conference with ACA. We may do that, we may not. We may have one with them, we may have one ourselves.
Thank you. Thank you. That was fast. Everything's going overall?
All right.
Need anything from me?
I got a case today on a 22-year-old who had aortic insufficiency on the basis of his PST. They had close, so I'm going to replace his valve. Ran up against a dual orifice tricuspid valve I'd never seen before. I think it's going to be good when we start getting all our stuff together so we can do these cases.
Training's going well overall. I mean,
Are people learning things?
yes, lots of good experiences. Lots of ECMO babies. They even had a baby coded yesterday in cath lab. I mean, they've had quite a bit of experience there. I mean,
A lot of complications.
oh, yeah.
I hope you don't have too many questions.
Quite a bit of experience in there, so.
Okay,
I don't know. All right, sorry, I didn't mean to
I
interrupt you, but she was yanking me.
Oh, yeah, no, you're good. Go, absolutely. More important than
Introduced and then I abandoned.
No, don't worry, we're good. We're rock and roll.
I get that a lot.
So
I
add
need to work on it.
email
That's all right. That's okay.
Thank you so much. Quick question for you though, as you're heading out.
I'm talking to them, I'm talking to her, and you're pointing, I was like, oh, like, yeah, sorry.
Yes, very.
Are you guys excited?
I am,
Okay, good.
because it's like almost everything that I saw there, but it's just more related to
Yeah, so you
Got
got it.
it. So it's interventional radiology and
Excellent. So today we are working on a plan for you as far as what the rest of your training is going to look like, where you're going to go. As far as you're in the PICU today shadowing, I'm not sure yet, but this is maybe something to consider. We might send you to St. Pete at All Children's to the cardiac unit and just have you start training there. And then after you're completed there, then we may consider putting you back. Just something that's up for discussion. Or you may go to PICU first prior to. How do you feel overall going straight to the PCVIC? But I think the pediatric part is not going to
worried about all this transition from adults to the peds.
Yeah.
And not going directly into
I think that you're going to be learning training. You actually be doing hands-on. That's the plan there. So I almost, with everything, with your background and your comfort level, I can mind feel more comfortable sending you straight to St. Pete. I mean, you get on the ball with cardiac training. Because that way you can be behind. As far as where everybody else is. So it's definitely something I'm considering. So if you have anything planned next week, if you have any planned, okay. July, no special plans. So, okay, all right. So I might just add you to the training for next week. Yeah, or I will contact you. I like to have cell phone numbers because I Sometimes, if anything, you've got 2 emails instead of 1. Why? Don't worry about it. No, absolutely, yeah. For training, you're gonna be day shift. All training is gonna be on day shift. And then after that, we'll readdress it, you and I, and Stephanie, and you tell us where you want to be and where you feel. The need is more nights. However, we want to kind of readdress and see how you're feeling and how everything's going. I'm excited. We have a great team. Everything's right together.
I have one that I imagine
Finding people.
opening like I really like that.
Yeah, and and then when you're trying to learn yourself, the cardiac piece, because I haven't worked cardiac, I work ICU, PICU. That's where I came from. So when you're trying to retain as much as you can, learn as much as you can to be bedside, but also be their manager. Okay.
Great, because I happen to, because I usually go in, I reference.
I'm getting it. And I have good staff that, like, never mind help you, or, very, yeah. So what's your cell phone number?
Start with.
Okay.
I know that's a lot to ask for, so that we can be sort of prepared, based on his conceptual, I mean, he seems really in depth really quick, which is great. However, if I'm not,
So what's your last?
just as others already are prepared, I don't want to seem unprepared.
Diaz Gutierrez. But I have Cindy Carolina Diaz Gutierrez.
I knew there was another name in there somewhere.
But in the, I think in here, I'm only Cindy Diaz Gutierrez.
Okay.
Okay. And I did verify the same, they have to modify the classification and all. And so the list of class 1 through class 6.
Perfect. We're starting out. We are getting a field guide. Pocket manual, it's $40.
Over the next month, we'll
Choose the first one. They're putting it in order for us at all children. They're ordering them in bulk. So they are $40, and I think I did send out the email to you. I'm not sure if I did.
Centrology of flow.
Maybe
An older child is less risky.
But it's a pocket field guide. It's
Okay.
a small, little hand, So I'm ordering one, she's gonna order one, so if you want one, okay, okay. Okay, excellent. Just give me the money when I get
Yeah, as long as I can play through that.
Yeah, no,
Okay. And I'll be there Monday, Tuesday next week, and then she'll be there Thursday, Friday next week. So if you start there next week, I will give you everything you need to know, I'll tell you where you need to go, what you need to do.
A lot of the same.
Everything, by email and phone call. I'll do both, I'll email you, then I'll call you next week. You're welcome. I'm excited.
That would be great. That would be great. And if, as long as, we're bouncing ideas off, and just so it's a sort of a flow on what type of procedures he's going to do, sort of gets at least a preparation before he walks in and says, okay, we're going to be doing this next week. We're going to be like, well, what?
Yeah.
I don't want to be sort of a last minute and sort of not know. But that would be wonderful. I think that would be.
How was your first week?
Great.
Yes. Okay, thank you. How was your week in St. Pete? Your
Well,
day?
my day. Well, it was good. It was just the orientation part. So, we went around. Hopefully, all the paperwork is good to go for Monday. I haven't heard anything.
You'll know.
So
If not,
it's wonderful. And it was really nice there. I've been there before, sort of just as when I was in nursing school. But it looks familiar. It looks really exciting. I'm just sort of concerned at the whole horseshoe shape. I'm sure it works for them. Yeah, and in general, is that sort of like the scheme of how everything's going to be now?
I think
as opposed to a more centralized. My only concern is like I see that, if you're in your room, or even up in maybe because I come from a circle. So we had a centralized tele. And I mean, if you knew if the patient in bed 1 was crashing and you had, 8 and 9, you sort of could venture over here with the horseshoe shape. My only concern is I don't know, even if PICU was going, I don't know that a patient is going down that over there, and there's no way I can get there to leave these 2 here. So is that going to be like a standard?
It's more of a box, kind of, sort of. It's a square.
Okay.
One big circle.
Okay, with a centralized.
There's a thing in between, however, I don't really know that it's going to be open to both sides. So it's not as big. Now, mind you, it's probably, my guess is if we're in this room, we'd be standing in the middle of it, and the units would be that way and that way. And that's the distance. As far as
that's not that.
But as far as I know, I don't know if they're knocking down any walls that I'm unaware of, but I've been on that unit before, and it's not that big as far as width. So my guess is that it's kind of a circular type, squarish type
But things work.
Yeah.
I mean, you know, I'm sure things work, and I'm sure things work upstairs. I haven't witnessed a lot of team collaboration.
Right.
But I don't know
that
if
is something
that's
that they're
the
struggling
crew,
with, kind of.
or
Yeah.
if that's the.
I think it's a little bit of both.
Okay.
What they have over at All Children, they have 22 bedroom, and it's very large, and it is like a big box like this. So if you're on one side, you really don't have any clue what's happening on the other side. But they tend to keep their sicker patients in the clinical area here, and that's more where the monitors are. That's where people kind of hang out, and then you know they keep computer growers, which you know you need to keep an eye on it.
Yeah.
But you know, so if the alarms go off, you can still hear them in the centralized area.
Okay.
My vision we're probably going to have sicker kids here because those are the two ECMO beds. So this wall has ECMO, this wall has ECMO. There's one ECMO here, one ECMO here. So I think all sick babies are going to go in those 4 beds.
Great.
And then with the less sick, back in here.
Okay.
That's my vision.
Okay.
Who knows what's going to happen?
No,
but-
of course, and no, and I don't mean to make you speculate.
No.
I don't mean to.
That's
that
a
was just
legitimate
my
concern.
and I'm sure I'll see it all children maybe a different dynamic. I was just, you know, not too sure if that's always or like you said maybe because there's a lot of shifting going on. I just didn't see a lot of collaboration.
Right.
It was just like you sort of, and I say it in a good way.
Yeah.
You know, you stay in your little cove.
Yeah.
You know, and you're not saying, hey, how are you
Yeah.
doing? Can I get you anything? How's your patient? You know, I didn't feel that, not that we should share a lot of patient information like that, but
I think we
I'm
should.
still on the floor with you. You're my buddy, especially in our unit.
Right.
We're a bit smaller.
Even if you're there, or
You
even
know,
if
what's
you're there.
going on
Yeah.
with that child? You know, are we looking at a
Am I gonna need to help you
or
today, or-
different
yeah.
rhythms?
Right.
You know, just for a second set of eyes. Hey, because if we have 2 patients and you're in another room, I don't know.
Right.
You know, and I mean, I know we can set up the monitors to see your other patient, but still things can start to trend.
Right.
And if we pick up those trends, we'll be good. Where if no one's trending or no one's even looking, you know.
Yeah.
That's just, I mean, I didn't know, and that was my only maybe uncomfortable part about being upstairs. And some nurses would talk with each other, and some wouldn't, you know. And it's cool because even if you have a sicker
And that's not going
patient-
to happen on the unit, just so you know.
No.
No,
And
what
I
I'm saying is, if you
I
do
just
feel
feel
that
like
happens,
a big team player.
and so am I.
Okay.
And I have to say, that's one thing I preach because I came from that environment.
Okay.
I worked at the Q. That's where I grew up. That's where I.
Sorry,
that's why
I see this as
You're
an
not.
outward
Do not apologize.
but
But I left there for a reason.
Okay.
Because I am not like that. Right. I'm more about teamwork.
Yeah.
I'm more about
I just
camaraderie.
think it's safe.
Yeah, I'm more about helping each other out, and that's where I come from, and I know that they struggle with that there.
Okay.
And especially with the new construction, even more so.
Okay.
So that will not happen, and if you do notice or feel that is happening, I would really like to know, because I'm very much strict on making us a team. We're not. It's not.
Okay.
It's not
I mean,
gonna be like
I'm
that.
just used to learning all the time, and I just felt like, oh
Yeah.
my gosh, you know, and then
Yeah.
it's like, well, I can't talk, you know, we're not going to talk about it. And I'm just like, well, okay, I haven't seen that before, but I'll figure it out. Okay.
Right.
So it's
No, because I'm going to be honest with you, I'm going to be very much in everybody's business, because this is
Yeah.
a learning process for me. I am your manager, however, I have not worked cardiac, so I want to learn that cardiac piece. I am an
That's
ICU
the
nurse.
hunger, though.
Yes.
Where we're
Yes.
not coming, you don't come in with already that, you know, where you walk this path before.
Overconfident, confident, yeah.
No. And I think
No.
that'll be even best. But I'm sorry to present it as such.
No,
and
I
I don't
appreciate
mean it in
your
a bad
honesty.
way.
No, I appreciate it. I'm telling you,
You
I
know,
really do like the honesty.
I just felt that, you know, not that I mean, and I know it's just sort of like, so no one wants to, okay, you don't swamp. It's just not, you know.
And the other person is not.
Yeah, and
It's just
even
that.
so, it's just not,
Yeah.
hey, how are you doing? There's like no, maybe I just done, maybe just some of the crews, and I know night shift or day shift, it really doesn't depend on which one you come from. Some people just don't, I come to do my job and that's it. So
go home.
I missed, you know, I don't know, but then again too, I was thinking, well, maybe because some of these are new nurses now. I'm a very new nurse, so I've only been, you know, but maybe coming from places where, I mean, my mentors were there 20 years, but there's such a group collaboration, no one leaves. And that's what I sort of wanted to make argument.
Right.
I think you have a great
Better.
and I'm, I met, you know,
better.
a couple of us
Yeah.
so far, and I really think
Yeah,
that
no.
everybody's of substance and great quality and character, and I'm excited
Good.
to
I'm
actually
excited.
see it really, really work.
Yeah.
Really work.
I
So I
think you're
do
a huge
appreciate
asset,
all of your time. Well, thank you, but I mean, you guys come with a wealth of knowledge, and you're quiet over there in the corner. I'm like, what is she saying? But
know,
great, no, but great.
I always look over
great
and I'm like,
answers.
volume.
I know, well, I know, where's the book? That's what I'm like, Rich, she's pulling that. That's like textbook.
I
You
know,
are
right?
Right
Yeah,
on.
yeah, she's good like
That is so awesome, but.
She's my textbook. She's my walking textbook.
I know,
I
just
like to have her
turn
next
to
me.
reference page 57.
I know.
What is it?
I'm like, wait, tell me what does he mean by this? And sometimes when she doesn't know things, I'm like, oh God, I feel so much better. Because I feel so
I
stupid.
definitely don't know everything.
You know what I
but
mean?
I have some.
She has a good base knowledge, but when
Yes.
it comes to certain things that I don't know, it's like I want to ask, but I'm like, I should ask that, and I always ask her. And
Right.
when she doesn't know the answer, I'm like, yes, I feel good that she doesn't know the answer to that.
But I think too, though, I think maybe is that, I don't know him, I've never met him. Now, is that's the sole cardiac surgeon or the main?
That's the
That's our
sole
main
cardiac.
guy.
That's our main cardiac.
Okay, all right, so he's gonna be doing most of the surgeries, and then from there, we
Yeah,
figure out.
intensive is starting July.
Okay, our own.
Yes, there's
from-
going to be our own, and then we are also sharing with St. the group in Tampa.
Oh,
There's a group in
right.
Tampa who they'll be coming as well.
Okay,
So-
okay, so that there's that, so then that collaboration is
Yes.
golden, then it's just that collaboration.
Yeah.
It looks like they rock a little bit.
Yeah, they decided to go ahead with the patient from CP as well. So we're going to be using that. So
Very good, well, wonderful.
Lots of
wonderful. I
collaboration.
look forward to it, yes, and then, updating schedules coming August.
yeah, I'm
See how
trying.
he
I have to wait
goes.
and see how
No.
this goes, and
Right.
then I'm probably going to be pulling most of you guys and asking for help.
Okay,
Beginning
yeah.
of August.
Okay.
Because that's crunch time, that's do or die, we gotta get things ready, get the
Right.
ball rolling, make sure
Absolutely.
that we've done everything that we need
Absolutely.
before we actually open. So,
Great.
and then we'll probably continue on with training depending on
Of course.
what our volume is gonna be.
Of course, wonderful, wonderful. So I
And
look,
staffing.
okay. Well, I look forward to it again, ladies. Thank you. Do you want sheets? When are these sheets due? How do these sheets go for like the TNAs and all
Give
of
them,
that?
you can give them to either of us,
Okay.
when you're done, whatever day you're done.
Okay.
In
Or-
St. Pete?
Yeah.
Okay.
Or if say.
Or like the one from like Wednesday, I just happened to fill out just, if
I go,
anybody
yeah,
was
take
here just to look at it?
Yeah, I could take it for you and get it.
Okay. Well, it's not even a rush, just sort of that, so it doesn't start
I'd like to
getting
get it
back.
back and out of my hands
Okay.
anyway, so.
Wonderful.
And
So,
How
what
about
are those-
today's lecture? Did you plug in?
No, I couldn't find the thing, but it was only an
Have
hour.
an extra?
I photocopy, are we allowed to photocopy this?
Yeah, actually, I have some.
Photocopied and I
I
cut
have
it.
some in my bag.
So if
here.
photocopies are good, I have copies. But I can, you know what, I can always give that to you on Monday. Don't even worry about that. Just take that one for right now.
Okay,
As long as that looks good to go, then I have a template.
perfect.
And then, this guy, then that's
Perfect.
rock and roll. And the stipend goes $45 for
40, yeah,
each
you
day.
didn't put the 46,
Don't worry, no, because
so.
it was only half a day. I didn't work. No, it didn't work.
I know, but
There
still
was no
put you in,
work.
didn't you?
$4. No. A yogurt. No. No.
You're right.
So we'll rock and roll with that, and then we took care of all the reservations and everything, and I'll keep
Everything,
you posted, like I said.
Keep me
I think
posted.
we'll be good. It'll be fine, I'm used to traveling.
Okay.
So Tampa
Well,
and
God
St.
bless
Pete,
you.
it's not, no, it's a straight shot.
Yeah. Yeah.
So that's why. Wonderful, ladies.
Thank
I
you
look
so much
forward
for
to it. Thanks so much. And, other than that, scrubs are okay. Anything else special that they sort of want, or just rock and roll, just get
Scrubs.
hands dirty, ready to
No
go?
Florida Hospital jerseys, I mean, no
No,
Florida Hospital
I
logos.
don't have any, I'm
No watches, rings,
no.
Studs, only
Okay.
studs.
Okay,
Florida Hospital policy.
wonderful.
Great. Florida Hospital dress code.
Fantastic.
Studs and maybe a ring that they don't.
No, no,
Encourage it.
no.
just like a band is all you
No, yeah, no. Kristen loses things.
Yeah.
I'm bare minimum.
Yeah.
We'll have a great weekend. And I think today I shadow. Last day of Tuesday.
With that person